The Charles Stewart Mott Department of Public Health focuses on population health from its home base, the College of Human Medicine's Flint campus. Being embedded in the Flint community allows the faculty and researchers to understand the assets and needs of the community while studying Flint's most pressing public health issues. Spartans work side by side with community partners and healthcare providers in a community identified and community participatory public health focus model. Jennifer Johnson is the founding chair of the Charles Stewart Mott Department of Public Health. So, Jennifer, before we start our conversation with your colleagues, tell us a little bit about you're the inaugural chair of MSU's first philanthropically named department, the Charles Stewart Mott Department of Public Health. So cool. Just tell us about your role and sort of the mission of the department.
Yeah, so we're really excited. This is the only department in the country that I know of where the department itself has been built in partnership with a community. So not just individual projects, although it is individual projects, but the whole department at a structural level is partnered with the Flint community. It's what brought me here as our first research professor in 2015, and I'm convinced that leaning on that model is why we've been able to be so successful. And, you know, it was Flint's idea, actually, to have the department here in Flint. They approached Mott Foundation and found a way to fund it. And we're just really honored to be here as faculty that the community chose to do work here in Flint.
Spartans will. So, Jennifer, what are we going to do today?
We are going to talk about some of the great maternal infant health work that is going on in our department. We're fortunate to have some of the national experts here, and we'll have a wonderful talk about what they've been doing.
Hi, my name is Madhuri Benna. I am an assistant professor here at the Charles Stewart Mott Department of Public Health. My work focuses on developing peer-provided interventions to help women connect with services and resources in the community.
Hi, my name is Gail Shipp. I am also an assistant professor with the Charles Stewart Mott Department of Public Health, particularly under the Pediatric Public Health Initiative. And my work here, I'm really broadly interested in researching maternal and infant health disparities and helping to improve maternal and infant health equity, primarily focusing on nutrition-related health outcomes, which most of it has to date been centered around breastfeeding and breastfeeding-related disparities.
Hi, I'm Steve Ondersma. I'm a professor in the Charles Stewart Mott Department of Public Health. My research focuses on the use of technology to try to promote maternal and child health, especially around improving outcomes regarding substance use, maternal morbidity and mortality, and things like that.
All right, so Maji, I'd love to start asking you a few questions. Why don't you tell us a little bit about your Mosaic project and the need that you saw and how that project is addressing it?
So the Mosaic project, it's an abbreviation for Mothers Advocates in the Community. It's an NIH-funded clinical trial currently developing a mentor mother-delivered intervention to address needs of women with history of intimate partner violence. So what we're doing is we're trying to train local women, mothers, grandmothers from Flint, and to have them to work with pregnant moms and women with children under the age of 5 who have had a recent history of partner violence. So we want to see if the support provided by moms can reduce future risk of violence and also improve mental health symptoms like depression and post-traumatic stress disorder symptoms. How Mosaic came about is, you were a part of the Flint Women Study, and when we were talking to 100 women and human service providers from Flint, what we learned was there was a huge need, especially for older women to give back and for younger women to benefit from the support and resources provided by older women in the community. So we wanted to make sure that we address existing needs by mobilizing existing resources in the community, which is our moms.
Yeah, I think it was really striking that our older women in the community felt that they had so much to offer and they were being left behind, and the younger women felt like they were needing role models. So this is a really cool program. And I think a lot of people may not realize that, some of the depression and PTSD that comes with partner violence can be a risk factor for future violence. And so can you talk a little bit about how your mentor moms are helping the younger moms?
Yes. So when we were recruiting mothers to serve as mentor mothers, honestly, having history of partner violence was not a requirement. But surprisingly to us, almost all the women we approached to serve as mentor moms also had some history of partner violence in their past, even though it wasn't a requirement in our program. And those women, because they've been through it, they know how to respond to it or even notice signs of partner violence or ways that women can plan for their safety, and they can work towards creating a safer life for the mom and her child. We do not want to put our moms in this need. It's a tough call for someone who is also a mentor mom. We also make sure that there are resources and support and services for these women, even though they are a lot more knowledgeable about their resources in the community than us in many ways. It created a great opportunity for them to know, to share what they know, and to also create a place for others to benefit from.
And if the program is effective, do you hope to scale it up? What do you hope the next step looks like?
Yes, so Mosaic initially was created in Australia, and it was tested in a fully powered, randomized controlled trial. And they did not evaluate depression symptoms. They evaluated depression, but it did not improve depressive symptoms, and they did not test for PTSD-related symptoms. Now that we are creating Mosaic Plus, which also has an added interpersonal psychotherapy component that responds to those mental health needs, by the time we're done with pilot RCT, our goal is to have a fully powered trial tested here in Flint community and see how the support provided by mothers can indeed improve mental health outcomes for this population.
And for our listeners who don't know the language fully powered trial, that means bigger and better, right? Just scale it up.
Yes, absolutely. Bigger with probably hundreds of people and better for sure.
Yeah, to provide the services. And you were also involved in creating a women's center here in Flint at the YWCA. Do you want to tell us a little bit about that?
Yes, the Women's Center, everything about women in Flint basically is my entryway to this community. I came in as a postdoc a few years ago, and you and I started talking to women in Flint, and as part of the Flint Women's Study. And what came out of that study was during our dissemination workshops, we heard that the women needed a place, not just to go and do stuff, but a place where they feel empowered, where they feel safe, where they can acquire the skills and trainings they need. And one of our community partners picked up that need, and they wanted to respond to that need. That was when the YWCA of Flint reached out to us, to our team, and we were involved in creating the Women's Empowerment Center here in Flint at the YWCA building. It has a training component. It has a place for moms to talk about jobs and whatever need they may have. And now that Women's Empowerment Center is operational here in Flint.
Wonderful. It's been operational for a couple years, right?
Yes. The official ribbon cutting happened this past October, but it's been going for a couple years, probably 2-3 years now, because the conversation happened at the dissemination workshops back in 2018, and right then our partners decided to create a campaign to establish the Women's Empowerment Center, which I was a part of, and we did a fundraising, and all that led to the Women's Empowerment Center that we currently have in Flint.
Yeah, and I think what you're talking about is a great example. I think sometimes when people think research and researchers and professors, they think that we are just like in a lab somewhere, all in lab coats. And our work here is really about understanding what people need and finding the best most effective, cost-effective, scalable ways to meet those needs. And so I think that the studies that you shared and the project that you shared are great examples of that and great examples of what MSU is about. Talk about, because you do work that's both international and local here in Flint, talk about how that works together for you, or how you think about, some of your work that's in Africa and how it intersects with work here in Michigan, or how do you think about that?
I'm someone trained elsewhere, and all my research up until I started this postdoc program was based in Africa, specifically in Ethiopia, where I worked with rural communities in terms of creating primary care-based mental health access for people with serious mental disorders. And then I moved here. For the first couple of months, maybe, I had a confusion to see where I fit in, where the expertise I bring will fit in. And that was when I realized it's about people. Like, it's not about places, but honestly, it's about people. So here in Flint, as I work with incarcerated populations or women, pregnant moms from the community, this is a social justice work. We're trying to make sure that the people we work with have better quality of life, better access to care. They can realize their dreams in life. So that's what keeps me grounded in terms of an international person here. But even speaking about barriers to access to care, I worked with low-income population elsewhere, and I'm here in a high-income country with lots of resources, but still have barriers to services. So we're trying to narrow that gap. We're trying to make sure that people have access to care, and that work is what ties my two worlds together.
Thanks so much. Yeah, I know that we've talked before about you helped to create the first mental health hotline in Ethiopia across the country. And I know I talked to you after the weekend, and you've talked with some health minister or head of state from Africa who's seeking your advice on mental health care access. So I'm always very impressed with the reach of the work that you do.
Thank you. Yeah, we did campaign for a national mental health hotline, and we got commitment from the Ministry of Health to dedicate 4 lines for mental health service. And after we got the lines for the National Mental Health Crisis Line in Ethiopia, we still had a bunch of things to do, and I was calling for help on social media, and that was when my work also got a lot more visibility, and some government people, both from my country and from other African nations, also reached out to me to offer help.
Yeah, I know that you have a very active following on X, and I don't know if we can say that, but if you look at her at Ethiopian Nomad, she is powerful, and as a matter of fact, once got an apology from one of the leading medical journals when they published an article saying it represented international perspectives, but all from high-income countries, who contacted her personally to apologize. So that is our Dr. Maji Dabina.
I don't know how to say what I think about this experience, but yeah, I use social media for advocacy, and there were times when I interacted with a journal, and indeed that led to some productive publication as well.
All right. Well, I'd like to turn our attention to Dr. Gail Shipp, who's also here and doing wonderful work around maternal infant health. Gail, would you like to introduce yourself?
So my name is Gail Shipp, and again, I am an assistant professor through the Charles Stewart Mott Department of Public Health. And most of my research, how I kind of think about it broadly, I want to impact and improve maternal infant health equity. My training is through human nutrition, and so, most of my research has been focused on nutrition-related outcomes, particularly impacting the mother and infant health diet. And to date, it started around breastfeeding promotion, which has moved more so into breastfeeding disparities, particularly for Black people. And as of recently, I'm kind of interested in addressing moving more so looking at maternal mortality and morbidity, since it's, a crisis impacting a lot of Black women, not only in Michigan, but nationally.
And I think not everyone may be aware of some of these disparities, both in breastfeeding and in health and mortality, maternal health and mortality generally. Do you want to tell us a little bit about the disparities that you see and why they matter?
Yeah, sure. So, and I think to just kind of set it a little bit further back, like when I started working at WIC as a nutrition educator. And so oftentimes I didn't know, but I would see breastfeed, or families rather, and, providing them the education and providing them around nutrition and encouraging them to breastfeed. Oftentimes they still had these challenges and barriers to not be able to do it or meet their breastfeeding goals. And so that really just kind of prompted my curiosity, wondering why, not really realizing it's sometimes like the structures and the systems that prevent them, their environment, that prevent them from being able to successfully meet their goals, whatever those may be. And so that really is my why and why I wanted to push and do some of this work. But yeah, you oftentimes, now the breastfeeding initiation rates relative to that are relatively high, but usually when moms go home, they don't have that support or access, in which you see duration and breastfeeding exclusivity rates drop significantly, particularly for Black and Indigenous populations. And so, again, aspects of social support, having workplace supports, even maternal maternity care leave, all of those things really do sometimes impede a woman or breastfeeding family's success to be able to succeed in their goals. So.
And why is breastfeeding important? I mean, I know you're so immersed in this in the work you do, but for folks who haven't breastfed lately or ever, why is it important?
I mean, it's the first start for an infant, right? And so getting them off to the best start in terms of nutrition-wise, right? And so that's the main thing, wanting them to get started and have the best source of nutrition, and it comes straight from their mother. And it's free, And so, and then also, in addition to that, there's many benefits, not only for the infant, but also for the mother. So when you think of different cancers, chronic conditions, it definitely reduces the risk of those things. And so we try to push breastfeeding as much as we can, particularly for that. And also it saves lives, and it reduces the cost, within the world. So.
Yeah, formula's expensive. So, what is your work doing, or what have you done to help support breastfeeding or help support address some of these disparities in maternal and infant outcomes?
Yeah. So I've participated in a couple of studies, particularly mixed methods related research, where one study in particular, in which I enjoy. It was called Mama Bear, but it was a NIH R21 study by the investigator Jean Kerber. But that was some of my early dissertation work, in which I interviewed Black women who wanted to breastfeed and really just wanted to hear from them some of the challenges and barriers to not being able to breastfeed. I think it's important to hear from the community themselves and the people themselves. I think they have the strategies, they know the why and the issues that are out there. And so rather than having this top-down type approach, let's hear from them. What are their challenges? How can we figure this out and support them so that they can meet their breastfeeding goals? And so I think that was, being able to just interview them, that was very impactful for me. And then another piece, and I don't know if that has anything to do with it, but just thinking back to my early work, I was the one who would, give the education as a nutrition educator. So, but never, I hadn't had a child at that point. So, part of my lived experience now I do bring to this work. And so, and when I say that, being not only a Black woman, but now a mother, and actually experiencing it myself. So regardless of your education, things of that nature, I remember being in the hospital and they tried to force me to formula feed my infant. And so, just actually experiencing those challenges personally, it became, so at first it was more professional, but it became personal. And then even thinking about maternal morbidity and mortality, you know, sometimes even now with some of my current studies that I'm now embarking upon, it became personal. So when you think of some of these indicators that these Black women are experiencing when they leave the hospital, not knowing, I also experienced that, not knowing, right? And so, it's personal for me now, and wanting to and move the needle along and help support Black families, particularly to improve their health outcomes. So.
Yeah, and I think, people may not know, but, Black moms in Michigan and nationally die at 3-4 times the rate of non-Hispanic white moms, and Indigenous moms also are more likely to die. And I've been hearing, from some of our colleagues and partners that there are Black women who are scared to have children for that reason.
Absolutely. Yeah. And I understand it, sometimes you feel like you go to the hospital and you're unsure what your outcome may be. And so learning that, one study currently that we're doing some data collection, it's a partnership with Michigan Hospital Association, as well as Michigan Council of Maternal and Child Health, where we're interviewing Black women and learning about their birthing experiences, and then also postpartum experiences, really to try to get a better understanding of what's going on to try to improve these health outcomes. And it's interesting to kind of hear their stories.
And you recently got a grant from the Robert Wood Foundation, right?
Mm-hmm. Yep. So I recently received a grant from Robert Wood Johnson Foundation. It's Health Equity Scholars for Action. And that grant is really to support underrepresented minorities early on in their careers to do this kind of work, right? And so with that grant, I was thinking of what to do when I submitted, but I thought it would be, especially being a new and early faculty immersing in Flint, I thought it would be helpful to uplift some of the organizations that are here doing the work already, right? And so we have a lot of different maternity care organizations, and oftentimes they don't have the evidence behind them, or don't have the funding to do that formal evaluation piece. So I thought maybe it would be nice to kind of collaborate with one of those organizations to evaluate the work that they're doing, and then also to see if there's any influence or association with maternal and infant health outcomes. And then another piece of that, because I like mixed methods research, right? So it's a combination of quantitative and qualitative methods. And so I oftentimes like to immerse myself in doing interviews with whomever, the population that I'm essentially interested in learning more about. So with this, the second half of that, the qualitative piece, I will I'm looking to engage community partners as well as Black families around the trust and acceptance and utilization of different maternity care approaches and initiatives that are in place to support, that are deemed supportive. So, yeah.
And how is this work? How do you hope it will turn into action or different care? Like, what's the next step that changes things in the world around these issues?
Yeah. So the hope, again, I think those answers are centered in the community. So I'm going to listen, and then from that point, hopefully any policies that come from that, try to push and move those forward, and then maybe some additional collaborations with the communities and grassroots organizations that exist to try to move, to support them as well too. So that's the hope of that.
Wonderful. Is there any other aspect of the projects you're working on right now that you want to share with folks?
I'm also engaged in ECHO, and so that is the environmental influence of child health outcomes, in which it's a longitudinal cohort study, and it's on its second phase. And the component that I'm involved in is I'm a part of the PEDP plan, which is the plan to enhance diverse perspectives. And so, yes. And so with that, this phase of it, we're really trying to increase diversity with our population. So the recruitment is really being intentional and focusing on the urban and rural areas, which is Detroit, Flint, as well as Traverse City. So my piece of that is really to just kind of engage with participants around ECHO and how they think of ECHO, and then also the community collaboration. So we're looking to engage in interviews again with partners, again about this gap between research and healthcare, and so all again to improve maternal and infant health outcomes.
Yeah, and again, for folks who maybe don't use words like longitudinal cohort study, it's a large group of moms, pregnant moms and babies, right? And they're looking at some of the environmental exposures like chemicals and different things that happen to them, and then looking at the birth outcomes and the baby's health as they grow into children, right? And so then it's really important to have everyone represented.
Absolutely. Yes. So, and that's why they're really focusing to make sure that they have a diverse population for this cohort or this phase. And so I'm excited for that. And, this is the second round of it. So we're really just wanting to dig in and make sure that some of the surveys, when we're looking at the participant surveys, how do they, again, cultural humility, things of that nature. So, and again, what's the next step? So going into the community and our partners, talking to our partners in the community organizations, because oftentimes they have the answers and they know what's next in terms of research, and again, how to bridge this gap between those two, research and care.
Yeah, and I think, it's interesting, the history of medical research, because for a long time in drug trials, that's not really what we do. We do more behavioral work, but they excluded women because we were the anomaly and we might be pregnant. They thought we were hormonal or whatever, right? We were excluded. And then, again, from a lot of medical and public health research, minority populations were excluded. And so now we're having to do catch up around, what does health look like? What should health outcomes and health interventions look like for women, for people of color?
Absolutely. You said it perfectly.
Okay, well, why don't we hop to Steve for a minute? Steve, you already introduced yourself a little bit, but would you like to introduce yourself again and tell us a little bit about some of the work that you do?
Sure, thanks, Jennifer. So I am Steve Ondersma. I'm a professor in the Charles Stewart Mott Department of Public Health. And my work comes down to, I think, a simple formula and an important distinction. So that formula is that the impact that we have on a population level is a function of two things. It's a function of just how effective our interventions are, our programs, our policies, our campaigns, and how many of the affected population they reach. And that's a really important part, because that distinction is this, that there are two broad groups that people can be sorted into when it comes down to the sorts of interventions that we might create. They're treatment-seeking groups, and they're non-treatment-seeking groups. So the treatment seekers are those who are eager to find some sort of a program and some sort of assistance, either looking for it, or if offered, will happily say, yes, that sounds good, that's something that I need, and I'm happy to participate in that. The non-treatment seekers are people who are not currently actively looking for anything like that, and when offered for a whole host of reasons, will say, no, not really, thanks, but that's not for me. They're both incredibly important groups, and both sides of that simple formula are incredibly important. I'm just interested in the reach side of the formula, how many people we get to, and in those non-treatment seekers, who are often the majority, especially with substance use. So, for example, with substance use, of all the 20-some million people in the United States who meet criteria for a substance use disorder, 85% have neither received any treatment in the past year nor feel that they need it. So that's a huge majority of that particular population that we have to reach in other means, not just through making great treatments available, although that's incredibly important, but by other means. And that's what I'm interested in. I intentionally constrain myself to the duration and the intensity of intervention that those folks, those non-treatment seeking folks, will take part in. So that means what I have to do has to be brief. It has to be something that is interesting and attractive and can be done quickly and easily and conveniently. How on earth do you do that? Well, for me, the answer is technology. Right now, 85% or so of us, of adults in the U.S., have a smartphone in our pocket or bag or within a few feet of us right now. And that number is only growing, and it's mostly driven by age. So it doesn't vary with socioeconomic status. It doesn't vary based on demographic factors. It varies based on age. If you're 18, you've got a smartphone somewhere, almost inevitably. And if you're 90, the odds are less. My own 90-year-old mom happens to have one, and she is, I'll say, okay using it. But they're quickly becoming ubiquitous. And so that, for me, is an incredible opportunity to develop technology-delivered interventions that are attractive and of interest to those non-treatment seekers and can potentially do some powerful things, especially when we expand it to multiple levels. So when we're trying to improve pregnancy health and maternal health, it's not all down to that person, right? They can do some things, and knowing some things can be extremely helpful in terms of protecting themselves, gaining skills, gaining knowledge, all kinds of great stuff. But their community level influences, their healthcare level influences, their influences of their family and the people around them, like Dr. Shipp was referring to so eloquently. So I think technology at all those levels can do really important things. It can't do everything. It can't do everything that the mentor moms that Dr. Debina is using can do. It can't do everything that a professional nurse educator might be able to do, but it can do really important things, and that's really where my interests lie.
Yeah, thanks so much. Yeah, and I've thought about this differently actually since I started working with you, in terms of how to reach the most people. And you've developed an entire technology platform, right, with the goal of reaching people all the way across Michigan nationally, including people in rural places that don't have, OBs around or mental health care around. Can you tell us a little bit about that?
Yeah, thank you. Great question. I love to talk about this. So when I started this process, and this was some time ago, I was kind of early into this. When I started doing this, I had RAs on labor and delivery floors rolling a giant suitcase behind them with a 20-pound laptop and a great big screen. If you had told me then about smartphones and what was coming, I would have wept for joy. It's really such an exciting thing. So started a long time ago, and I did what everybody else does in terms of thinking about technology-delivered interventions, which are sometimes called e-health interventions or m-health or digital interventions. I went and talked to a colleague at the computer science department, and I got a couple computer science graduate students, and they started making some stuff for me. And I had these visions of everything that they could do and how great it would be. And I quickly discovered that it's hard, and it's expensive, and it's slow. And I would tell these RAs exactly what I thought would be really great, and they would make something and show it to me, and I would say, and they would say, but Steve, that's what you asked for. And I'd say, I know, but now that I see it, it's not right. It's not what I wanted. Or they did something that was exactly the words I said, but not the intention or the vision that I had in my brain. I found out that I really needed that control. But the problem is I'm not a programmer. I'm not a coder. And I didn't have the time to teach myself, and I didn't have the time to be doing that by myself, to be coding everything directly. So that started a very long road of developing and funding and leading an effort to make software that lets people like me, investigators like me, directly make sophisticated, interactive digital technologies without doing any coding. So one way to think about it is like PowerPoint, but for digital apps, right? Anybody can sit down in front of this and make something, just like any of us can sit down and make a PowerPoint slide deck in ways that we never could have if we were writing the code ourselves, right? So that does lots of good things. Once we have that, it means that we can make things ourselves, we can do it faster, we can do it cheaper, but it also means we can share it. We can give it to a colleague, and they can take it and improve it or adapt it to their needs. And then later on, especially as we got the newest version, which was based on an NIH grant that I got a few years ago, that let us start from scratch with modern technologies and modern languages and make something far better. And this has just been such a labor of love for me. Having that means we can do something really important. Instead of making stuff that we think is great and maybe showing it to the community, getting feedback and making some tweaks, we can give it to them and say, here's how you use this software. What do you think is good? What do you think would be helpful? Let's do this together. Or you make something and show us, and we'll put it into practice. It's been a ton of fun. We do something called apathons, which are like hackathons, but sounds a little less sketchy, in which we get teams of community members competing in a friendly way to develop content with community judges and community raters who then say, yeah, this is the winner. Winner gets a prize, everybody applauds, and we put it out there into practice. We've done that in a lot of ways for a lot of things now. One of the places it's been most useful, which you referenced, is a program in which we're trying to implement this software at every prenatal care clinic in Michigan. We're up to, a little over 20 right now, which is good. We want to do better. But it's really important because throughout the state now, in urban and in rural areas, everybody's using this software. Everybody gets input into the software. The measures, the questions we're asking are mostly the same. We're identifying a ton of risk that otherwise might not have gone identified and providing a lot of interventions for things that otherwise might not have been addressed in any way. We're providing feedback to the healthcare providers. We're doing it at no cost to them. We scale it up very easily. And the health department, who's funding this now through a range of federal and state resources, gets access to our findings on an easy-to-use interactive website where they can see how things are looking at each of these sites across the state. So they can even do, in epidemiological terms, which is what's called surveillance. So, for example, kratom is a new synthetic drug that's being used out there. You can purchase it really easily. A lot of questions about its safety. They were interested in how many pregnant women across the state were using this. They asked us to add it to our software. We added it to our software, and they can now easily track across the state where it's being used, if there are any particular regions where it's being used, and they have that really in an almost up-to-the-minute fashion. So, yeah, that platform, which is called SciAS, and you can see it, anybody who's interested, at www.cias.app. It is an open-source, non-commercial, free research resource that is provided by Michigan State University, thanks to these grant funds. Any investigator has access to it. And it's become the linchpin of everything that I'm doing. It's being used now by investigators around the country and around the world. We're in, I think, 20 different countries right now, and I'm going to Ireland next week to do an all-day workshop of it for investigators from around the world. It's fun and exciting stuff, and it's going to be great to see what other people do with it.
And it's not just researchers, right? Because what's really cool about SciAS that I've seen is that you're democratizing the health app development process, both in terms of who can develop something that they think is useful for the community or the people around them, and also who can use it because it's all free. And so could you talk a little bit about that for people who may have an idea about, what sort of health app programming would be useful? And again, I just want to reiterate, when you're talking about community co-development, it's not like you're taking their stuff and selling it and making $1 million out of it, right? It's all free, it's all open source, and the idea is to put the power in the hands of almost everyone to create things that are beneficial for health.
Yeah, that's a great point, and is absolutely true that thinking again about that simple formula about that reach, one of the problems is having an approach that people can access quickly and are willing to access, even if they're not necessarily a treatment-seeking person. But the other piece is scaling it up. It's really hard with some things. You have to train people. You have to get it out there. These things cost money. What we make with this software and what community members make with this software is nothing other than a link that can be spread easily at no cost. There's easy scale up. There's no profit around it. Anything that we make, anything that others make, can be readily shared at the drop of a hat, as easy as an email or a text message. So yeah, that's a really key feature that community groups, local groups, if there's something that we've made that they want to use, they've got it. If there's something that we've made that they want to adapt to their purposes, we'll show them how. It's really as simple as that, and we're very excited about that piece as well.
You know, you and I are part of what we call the Miracle Center here at MSU. It's one of 10 national federally funded maternal health research centers of excellence. We were really excited to have one here at MSU, trying to address some of the maternal morbidity, which just is a fancy word for health, all different health outcomes, and mortality, differences we see. We see worse health outcome, maternal health outcomes for rural populations, for Black moms, for Indigenous moms. And how are you using this platform in that project to try to help with maternal health equity?
Yeah, absolutely. So we're super excited about that more recent project, which, as you know, is led by Chris Meggia from our Department of Obstetrics, Gynecology, and Reproductive Biology, and yourself. It includes multiple projects. Mine is one of those projects. And we're using technology to try to, as you said, to try to reduce maternal morbidity and mortality. And we're doing that in a few ways. We're doing it at multiple levels is one. So we're trying to coordinate and facilitate access to community services, which can be really confusing, sometimes even in what are called maternity care deserts, where there is not a provider or a labor and delivery hospital for very long ways. Even in those areas, sometimes there are services that can be really helpful, with home visiting being one. Early home visiting is available for free to any pregnant person in this state through the MIHP, the Michigan Maternal Infant Health Program funds. Lots of things are available, but it's confusing to access it. They don't talk to each other a lot. So one thing that we're doing is inside the software, we're providing a link where somebody can have a secure chat with a live community health worker who can say, tell me where you're from, tell me what you need, tell me what you're struggling with. I'm here to help. I know about things in your area. Let me tell you a little bit about how it works. And by the way, early home visitation is really cool. Can I put your name down? So that's one level. The other level is the provider level. So we're using technology to provide micro detailing, which is really just like micro education text messages for physicians in rural and urban communities that help physicians keep in mind the importance of really listening to their patients and of looking for these things that are rare but deadly. So, they have a tough job. Sometimes certain symptoms are just things that evolve and resolve on their own, and other times they're things that can be deadly, right? So to be reminded of those rare outcomes, they may have seen the similar symptoms a million times, but maybe this time it's something really important to really listen to their moms, especially the Black moms that don't always get listened to in the same way. So we provide education for them. We also provide something called a disparities dashboard, where they can get a sense of how the Black moms in their patient population and their that they treat feel about how easy they are to talk to and how trustworthy they are compared to their other patients. So if there are issues, they can just become aware and think a little bit about that. So that's the physician or caretaker level. We also provide those reports that I talked about. So women in the program who use this, what we call a pregnancy checkup, that talk about their strengths, their protective factors, the things that are going well, the things that aren't going so well, the things that are risks. We get a summary report to that healthcare provider so they have a good sense of what's going on and can follow up and can help facilitate connection to other sorts of care. So that's the provider level. Then there's the support system level, so the people around this pregnant woman. Things like parents, sisters, friends, father of the baby, anybody around that person who cares about them will get access to the software to be able to do really brief sessions, get text messages, telling them a little bit about things to look out for. What are warning signs? What are the things that that if she says, it's no big deal, I'm going to be fine, but maybe it's been going on for a week or more and it's something that really needs attention, that they can say, no, this is something we've got to talk about. I know what to do. I know who to call. We need to take care of this, right? And also just about how to support that person. So I learned from a colleague, you, about the importance of what can be called internally a sick role, where when you're pregnant, it's almost like you're really sick in that you should have certain things taken away from you. Certain duties, certain chores, certain expectations. You need to be protected and supported so that you can do your job right there, which is carrying a baby, delivering a baby, and taking care of a baby. So we can help with that as well by providing the software to the people around the pregnant person. We can help facilitate understanding and knowledge and education about how better to support that particular pregnancy. And then finally, for the pregnant person herself, that we can say, here are things that are normal, here are warning signs that you should watch out for, that you tell your provider about. Here are health behaviors that can really make a difference to the extent that you can do them. Here are health behaviors that can do some harm, and to the extent that you can help reduce these things, like cigarette smoking, for example, or alcohol use, the better off you're going to be. And here are some things that can help with it, and here are some places that you can talk to, some people that you can talk to get help with these things. So at all those levels, using what's really relatively easily absorbed technology that expands, should they want to use it to get access to more, and that refers them to other services, I think is a key approach to doing it, and we'll be testing that compared to treatment as usual at a number of sites around the state.
Some of the apps that you have had on this platform address, like you talked about, postpartum depression or preventing postpartum depression by getting good supports around people, substance use during pregnancy and postpartum, because it can be, so a lot of people don't realize that their use is maybe too much. And there's so much stigma around this, especially during pregnancy. I mean, it's really tough. And so, you're trying to get the information out into their hands so that they can do something with it that doesn't require maybe that first scary step of calling and making an appointment.
Yes, absolutely. And that's in fact how I got here. So earlier in my career, the very first grant I had was a project to help mothers of cocaine-exposed babies. There was a lot that we didn't know then. There was a great deal that we didn't know, including that cocaine was not even remotely as dangerous as it was thought to be, and that a lot of our response was based in some important biases. I've evolved a lot and changed a lot as a result of that experience. One of those ways is taking a very holistic approach, looking at all substances together, because frankly, it's the legal things that are far more often used and are causing far more damage in pregnancy. Like alcohol and tobacco, and now cannabis, are by far the most commonly used and are by far the things that are most likely to lead to negative consequences. So how do we do that? How do we intervene? How do we know about it in the first place? Because if you rely on kind of spot testing, you're only going to get a small fraction of the use that's happening, and you're only going to get a biased fraction, because when people spot test, or et cetera, all kinds of biases are going to come out of that process. So how do you make it universal? How do you make it safe? And how do you make it something that can could potentially have that population impact? So for me, that's how the technology was really born, was to do it in a way that is separate from the healthcare system, separate from anything that could lead to child welfare involvement or other sorts of negative consequences, that gave the pregnant person a chance to talk about this, learn about this, get good information, know how to get help, in a way that's safe. And that's really what kind of got me started on this whole road.
Wonderful. Yeah, and I think, like all three of you have talked about, the work is so well partnered. So in the center, you talked about, our third principal investigator is actually a community member from Grand Rapids, and your project is partner with community members here, and you have community members, developing app content. It is now possible to prevent postpartum depression. That's part of what Steve was mentioning. I think people don't realize that, and it's an important equity issue because low-income moms and moms of color are less likely, if they develop postpartum depression, to get to good mental health services, and there's worse outcomes for them and their kids. And so my colleague, Karen Zlotnick, had this great idea of what if we could prevent postpartum depression, which means stop it from happening in the first place. So there is now a class. It's called ROSE. It's Reach Out, Stay Strong, Essentials for Mothers of Newborns. That it's 4 classes. You take it during pregnancy, and it can prevent half of cases of postpartum depression, meaning you never get them. And it is based on this principle that Steve was talking about, that this is a time you're going to need more help than usual. Don't try to be a hero. Just don't. And, let's get some supports around you. And so this is now, it's been shown in 4 clinical trials to be effective. We've been scaling it nationally. And we're currently doing our project here in Michigan and in Massachusetts because we think the recommendations should be changed from moms at risk to every mom. And so we're enrolling pregnant people all over Michigan and Massachusetts to try to help advise the folks making the recommendations, the U.S. Preventive Services Task Force, for recommending this to every mom. And if you're interested in finding out more about ROSE or potentially getting ROSE, our website is www.rosemom.org, ROSE-mom.org. And, we would love to have that. But even regardless whether you do that, just know that it's possible to prevent postpartum depression. And, you can look for ROSE or another program that does that, because there's just no need to suffer. Oh, and I also wanted to make one note. I don't know if you guys have noticed, but we've been using words like women, pregnant people, postpartum people interchangeably. We recognize that not all pregnant and postpartum people identify as women. So, just so you know, if you hear us using the different terms, it's sort of to capture this diversity of people and gender identity of folks who may be pregnant or postpartum. Actually, Maji, let's go to you. What do you want to either tell us your ultimate goal for the work you're doing, or what you would like everyone out there to know?
I think I want to borrow your words. I want to give women joy. I want to see women happy. And what I do, whether that is the Mentor Moms or the research I'm writing, ultimately, I want to see women be happy and healthy.
Just thinking about it a little bit further, when you think of it, I think equity and justice, that's the work that we're doing, and particularly for me, looking at breastfeeding, I think that's just the vehicle for kind of doing the work. And the same thing like with Maji said, when you think about it, just wanting to make a broader impact, wanting to support moms, women, and improve health equity is very important, and trying to look at all the systems and how we can create policies to support Black and Indigenous women. That's the most important piece for me.
I want a lot of things. I think to begin with, I want to make brief interaction and engagement with technology to be a universal part of the health experience in healthcare settings. Secondly, I want open science, open collaborative science, working together, collaborating, even competing, to find ways to use that brief interaction to best effect to make a difference. And I want to see that difference being, in the long run, better maternal and child health outcomes, less morbidity, less mortality, better birth weight, less preterm birth in this country than in other countries. Right now it's the opposite, and we should be leading the way. And I want to do that through in large part through engaging with the community, and thank you, Jennifer, for raising that. Our first apathons were led by community partner Nina McKay from the Healthy Flint Research Coordinating Center. The Miracle Project that I'm doing is now co-led by my partner Athena McKay from Flint Innovative Solutions. There's so much great work to be done. It can't be done without community engagement, and I'm optimistic about what we can make happen together.
In settings like Flint, where we have a lot of mental health need, I also want to emphasize that lay provider or peer provider delivered interventions can indeed improve service engagement, and they can improve quality of life and mental health outcomes for these people. So I want to see peer provided services in many places, whether that is in labor and delivery settings or in postpartum care or in the first few years of life for the baby when the mom is actively busy with the child. I want to see that. And ultimately, as a policy response as well, I want to see funding for peer-provided services to be delivered in a more broader way to address mental health disparities.
Just kind of adding, we have the doulas are being supported and covered by Medicaid now in Michigan, so that definitely helped. That's an additional form of support for Black women, particularly during the labor and delivery setting, and postpartum, and so they can definitely support that mom. So, and just kind of thinking through it, oftentimes people don't know that, knowing the things that are available, the resources that are available to them. So really pushing those things. Again, lactation support, that's covered on our insurance policies as well too. So having access to that, finding you a lactation specialist that it looks like whatever that you can connect with. And so to help you particularly to meet your goals. And again, improve these maternal and infant health outcomes. So definitely having the knowledge to access the resources that are available, I think is really important.
Yeah, I would say that anybody who's interested in the apathon process and wants to take part in Flint, we're looking for testers, people who will review and rate the various submissions from the various teams. Go to www.pc-pramm.org/testers to learn more. We would love to have you participate. It's fun, and you get a little bonus prize. And if you're from a rural area and want to participate either as a tester or as a developer, forming a team and making some cool stuff, please go to that same website and keep your eye on it for more.
And I would just like to say, thanks so much for having us on this podcast to talk about this work. In here at the Charles Stewart Mott Department of Public Health, the community told us really clearly when we came, they don't want more research about what's wrong. They want research about how to fix it. So our work, we have a lot of people who care deeply about the populations that we serve, and we work really hard to do work, to change interventions, to change policy, to make services more available, to make things better, to improve health, and like Maji said, improve joy. And I would also just like to say, for people who are pregnant or postpartum, or people who love someone who's pregnant or postpartum, you are a vessel, but you are not just the vessel. Your health matters. Your mental health matters. If you have addiction, you still matter. You matter, just period. And so please reach out for help. Get the services that you need. There are a lot of things that are available. And if you aren't feeling right, if you're having physical symptoms that trouble you, if you're having trouble breathing, if you're having headaches, if your blood pressure is high, if you're having strange thoughts or feelings you haven't had before, go get help. And if you get ignored, make noise until you're not ignored, because you matter, and we want to see you be healthy.
For more on the Charles Stewart Mott Department of Public Health inside the College of Human Medicine at Michigan State University, visit publichealth.msu.edu. I'm Russ White for MSU Today.